Good evening. Welcome, all of my beloved colleagues today. This is our just regular storming session for you. We're trying to sit with you almost every week now. And whenever we are thinking that this issue will be important for your preparation, not only for the preparation of the exam, rather for any general physicians, rather to say, or any clinicians to come across a clinical challenge, we are thinking that this is important. For this, we are inviting you. My humble introduction, already in the meantime, and our institute, Moral Alert, and we're going to start the session now. So, this is actually clinical checklist how we can utilize, especially those who are OSCE candidate and preparing more or less now. You already understood that you need to challenge a case in the exam with a clinical problem. Most of the cases are having a clinical symptom, though there are some other issues that facing the investigation reports, breaking bad news, so on, many types. But the patients actually mainly coming to us with the clinical symptom. And we have selected today a very common symptom. Most of the time we discuss about it. So today we actually will be discussing here. In the last few sessions, we arranged the role play sessions about the symptom. But before the role play, we need to know the backup knowledge in our mind. We should have that what we like to ask about and how technically we can utilize it. We will try to discuss it here. So just try to be attached with us in the discussion. Before going to the specific symptom discuss, just have a look in the exam mark sheet by the examiner. And I understood that it is not only for the examination purpose. This checklist is a very practical checklist for all of us as a clinical practitioner or clinicians or physicians, whatever we say. And you see, they are grouped in one, two, three, four: consultation skill, data gathering skill, examination or counseling skill. Number four is management and investigation skill. The last one is additional issue, impression by the examiner. So our main agenda is here all the time for exam preparation. And this is important to know for the examinee, especially mainly that investigation planning is under the headline of management. Okay. So here the data gathering and the examination and the management of any symptom. For example, if you think. So we need to diagnose a case primarily, identifying many other issues. So if we take the history and another word, we tell the data gathering. Our proposed headlines are these in this way. And you can see some side box for the explanation. This one, the for the pediatric, for the geriatric, and any excretor related information is given there. And this for any female, PPP or like that. Most of you already know in the meantime. This is a summarized headlines. We will start with the greet and meet, then proceed on, so on. This is a prototype data gathering sheet or history sheet, but we have to modify it. We have to utilize it, rearranging the points from here. It is not that like 1, 2, 3, 4, 5, 6 sequentially we will go according to the importance. We may take the drug history earlier. This clinical understanding or competency will be established after discussing many patients, whatever in the role play sessions or in our real life face to face problem in our job place or in our institute. So This was a data gathering. After data gathering, we like to show you the examination planning. In the right side, it is designed in a manner that you will start the examination from the hand shaking. Hand shaking means you just touch the hand, and then one by one, general appearance. After hand, come to the face. So there are face many things you have to see as a part of the general examination, including fundoscopy also. So this anatomical sector wise, it is sequenced here. And finally, you will come to the leg or the lower limb and do it. So it doesn't mean that you will do each and every examination here. You will just think in your mind map that I will examine this area, which are relevant, then you will examine. Similarly, in the left side, the so-called general examination, and very fruitfully, we like to say actually general observation here, very important, appearance of the patient. So these also part of the checklist, including in the down point of care test. Below you see point of care test. And the right side, the orange color box giving you some examples of the point of care checkup or test. In the bedside, in the indoor patient, we say bedside test, including urine test, capillary blood glucose, ECG, SpO2, peak expiratory flow rate, even many other, even nowadays, POC-AS, point of care ultrasound. These are very, very advancement in our practice. In the OSCE time, usually you will not see any ultrasound machine there. But the time demanding that as a GP, you can do it. If you arrange, you purchase, you invest your money for purchasing an ultrasound machine, handy machine, you can utilize it, and it will be very useful for your financial purpose as well. Anyway, we are discussing mainly our academic purpose as well as the examination purpose here. So these are the examination points rather to highlight to have in your mind, including. So in the examination, if I show you one respiratory patient or presentation examination, it could be like this. There is again number one, two, from there in the left bottom, go up. So there, the general examination actually not mentioned separately. But in the point, in the box, you can see that we incorporated the general examination here. First thing is sanitizing hand and others. This is a prerequisite for examining any patient. Then from there, foot and you have to stand in the foot and during the examination and then see one by one and oxygen levels. Is the patient having oxygen or not? This is actually designed keeping in mind that patient presented with a respiratory symptom. So you see different parts, hands, nails, radial pulse, eyes, mouth, face, neck, and then seven come to the chest area and going down. This is an extended version of our previous slide. And these are the instruments you need to utilize it. Not in the not in the exam only, uh, even in your day-to-day life also. You may not have these maybe a costly instrument and other, but minimum you have the stethoscope, you have the blood pressure machine. So how will you utilize according to your checklist? Okay. In the holistic approach, actually, we like to say that these are three weapons, clinical weapons to collect the patient's informations, and then uh, aim of the investigation, as one of the skill is the investigation. And in our chamber practice also as a GP, we have to investigate the patient. But what philosophy we should have in our mind? You just look at. Philosophy is very common for data gathering, means history taking, for examination, clinical examination, as well as for investigation. We need to keep this thing in our mind, or must. If you think this thing in your mind, you can create your own checklist. But for your convenience, we tried our best to create a checklist for you. And day to day, very recently, we are connecting or posting it in our group. I don't know how many of you have seen it. If you need, you can discuss today with any other checklist also. Though we will show you one typical prototype, very common symptom checklist today. But keep this thing in the mind so that you can understand the reason of the point in the checklist, why it is to be asked, why it is to be examined, why it is to be investigated. So these are the very basic thing in the right box, this one. May I request for further strengthening, Dr. Javed, please, if you don't mind. Can you read the points are there, Dr. Javed? This is the main area actually for ours today to discuss. The
Okay.
one, two,
Fantastic.
three, like this. Yes,
Okay,
please.
but aim of history taking, clinical examination, and investigation.
Yeah.
One, to diagnose the disease and to exclude differential diagnosis. Two, to identify causes, risk factors of the disease. Number three, to identify complication of the disease. Four, to identify comorbidities. Five, to identify functional limitation. Six, for a proper management plan. Seven, to monitor disease or treatment effect. Eight, for research.
Yes. This is in the headlines, whatever we have thought of before. These are the headlines. And keeping all the things in the mind, we will go to the checklist. And for the exam purpose, we actually design the management headlines. These are the points. We discussed many often before also. And possibly you have seen in our YouTube video, these separate skills are discussed very elaborately. The consultation is skilled, data gathering, examination, counseling, management, including the investigations. So these not need to be explained much. And this is the total headlines of a complete, in short, a brief checklist we should keep in our mind as headlines, especially in the OSCE exam purpose. So this is part of the data gathering, focus examination. Then we reach to diagnosis, investigation, planning. Actually, it should be under the management headline in the score sheet. But in our practice purpose, after a probable diagnosis, we make an investigation plan. Okay. And below is the management plan. So when we do practice, we utilize this chart. Now come to the prototype checklist, for example, of a febrile patient. So this is the introduction, very introduction for you. I am just stopping once, few seconds, stopping this slide share and opening the next page. Just keep me 10-15 seconds. Dr. Javed, can you help me again, please? Can you see the screen?
Yes, it is visible.
It is just checklist, a data sheet rather. Okay. We have provided the sheet in the group also. How many of you have downloaded? I don't know, in a PDF for your easy participation in the discussion if you need. So, if you come across, if you encounter a patient of the fever, especially in the adult patient, so what you have to do? You don't know the diagnosis, but remember, patient have a diagnosis. So our practical plan should be modified. But until I don't know the febrile patient's diagnosis, we have to follow a generalized format, generalized information list where we should knock at. Okay. Already you have seen that our aim. So I will actually feel better to ask you in some points that why this point is important. First of all, this is very introduction. It is not the fever issue mainly. But by shaking the hand, you are getting some feelings. If in the real life situation, your patient will have high temperature, the hands and body part will be warm. It is not practical in your exam, OSCE exam, especially in the South Asian part. So this is in general introduction and other for each and every patient. After that, we have come to the second point. According to our the data or history sheet in the right side box, and this is the left side, these are the points. So it will be very big discussion, and most of you possibly know about the each and every point. If you want to ask me now that why this point, I will try my best. Or I will just ask you to share your opinion that why you will do. Especially, I am very interested to discuss this very silly important point when patient tell the doctor I am having high fever, high temperature, or the so and so. So, including onset, progression, duration, this very prototype discussion. You see, OPD cats, we have set a mnemonic for this for each and every symptom. But one interesting point you see, I'm sorry I couldn't mark it well. I would do it later today. The measurement, oral, axillary, and the reliability. Because patient may not have fever today in front of you, but patient had fever in the morning, today or yesterday. Is it much important? Dr. Javed, can you explain? Oral axillary or reliability. You are asking the patient. It is not that you are measuring. It is only part of the history. Dr. Javed, please.
Yes,
Is it
because
important?
oral or auxiliary will not be that much reliable. Exact temperature will be per rectal.
This is okay. This is okay. My question is
Yes.
that should I ask the patient? Suppose we are asking that, Mr. John, what was your temperature record? Patient telling that 103 degree Fahrenheit,
Yes.
103 degrees
Timing
Fahrenheit.
also very important, whether it's in the morning or in the evening or night.
Okay, this is diurnal
That
issue.
is
But
continuous,
now,
continuous.
now I like to ask you that I am asking Mr. John, Mr. John, did you measure in your mouth, inside the mouth, or in your armpit or anywhere? Should I ask in this question in this
Yes,
way?
I think. Yes, I think should be asked.
Now you understood. Other colleague also understood. My question is to all of you: how often, how many times did you ask your patient this question? First of all, Dr. Javed.
Not asking. Yes,
Not
most.
at all. This is my personal realization also. But our observation, our visual impression to the patient also, that patient having very high temperature, whatever it is, 103 or 104, sometimes it is practically not much important. We think that okay, high fever is there, we are managing the patient. But sometimes in a borderline situation, we have to categorize that high grade, low grade. So the area where the thermometer is put, it should be asked. Sometime nowadays we are using what is called, that is the laser related maybe, or infrared. It is called infrared thermometer. And there's some difference of that measurement. Okay. So this is very technical thing. And we are appearing for OSCE like a practical exam. So this is very practical question, right, Dr. Javed? Asking
Yes.
that did you measure the temperature inside your mouth or in the armpit? This is a common area. Okay. So when it is very important that the technical thing, another question also, how many seconds or minute you kept your thermometer in the armpit. It may be second question if patient is illiterate, very what I say, less conversant person. Even that question also important, that how many second you put there. But in general, this part also could be a question in your OSCE or even in our practice time in the real life. So in this way, this is the history, especially the presenting complaint of the fever. And second point is the red flags. So my beloved colleague, please, in this part, up to the red flag, can anybody wants to discuss or ask any question, please? Red flag important from the primary evaluation of the patient for the first time. And if you cannot identify this thing, it is, we're discussing a fever again, reminding you, it is in the concept or context of the febrile patient. This could be the red flag. But this could be the red flag for any other symptom also if it is there. Okay. So, Dr. Aisha, please. Dr. Aisha Mobashir, you are visible. Sorry, I'm asking you if you are free. Can you open the mic? Can you tell me that one any point? Dr. Aisha, sorry, not able. Dr. Homadat, possibly today here. HD, if I am right. Any colleague, please, you can open. Just tell me in the febrile patient, severe headache, why it could be the red flag? What is important to ask? Please, any colleague, please.
Viral
Dr.
encephalitis.
Iram. Viral?
Viral encephalitis meningitis. Viral
Yes.
encephalitis
Yes.
meningitis.
Maybe meningitis. So these are important. These are very, very important. Similarly, everywhere you see this is the list of febrile patient having the red flag, and we have to be aware and alert as well that I need to examine immediately or decide to send the patient to the hospital. And very, you see neck stiffness, photophobia, patient cannot move the neck and other. You are observing the patient. It is not part of the examination. Patient telling, I cannot move my neck. Patient is febrile. So we can think meningitis. Meningitis always important, always important. Okay. And still persistent vomiting could be nowadays in the South Asian countries, even in my country also, still dengue patients are there. So dengue different categories also, dengue without warning sign, with warning sign, severe dengue. Another special terminology is called the dengue expanded dengue syndrome, like this. But only persistent vomiting could be a red flag, maybe even emergency. You know that patient may develop electrolyte disturbance. And electrolyte disturbance could be dangerous also. Patient can develop arrhythmia also. Many things are there. So these are the point before specific diagnosis is reached. This could be the thing. Okay. So if you see side by side in the box right side, you see this is actually inbuilt in our history sheet. All the things are inbuilt, but in a technical manner. So you can make a comparison and you can try to compare this thing left to right side, left to right side. Randomly, I will ask or I will discuss something. So it's still about the fever, we are going down to see. And now come to the system based symptoms. The fever is non-specific. There is an focus of the infection in somewhere, some system. For example, what is the common system? Please, any colleague, you can keep your mic on better if you don't have any noise surrounding. It will be easier for me, doctor. No worry. Two, three, doctor can open the mic. Keep your mic open if you feel better. So here, the in the system is there. So number one system will be respiratory symptom. So how patient present to you in the OSCE? Patient telling, for example, that doctor, I am having the fever. What was actually our lesson in the second question? Who can remember and tell me, please? Try to be friendly, doctor. We are in a small group teaching. What will be the next question if patient tell that I am having fever?
Other
Dr. Iram?
problem.
Yes. Do you have? You can see in the right side box, maybe font size is not big enough. Do you have any other problem? So if patient tell any other problem, what could be, Dr. Iram? Could be that patient have the cough, right?
Yes.
So cough. Now you are focusing towards the respiratory system. Okay. Commonly in your
Okay.
exam, the disease is very simpler, not very complicated. And patient may tell, I am having cough as well as I am having tummy pain. Tummy pain means, Dr. Iram, can you open the mic, please? Just to discuss better. Dr. Javed as well, if possible. Any colleague can open the mic. So if patient tell that tummy pain or abdominal pain, possibly the disease process involving the chest as well as abdomen. Okay. So what will be your thinking? Patient having such a disease, febrile patient of the 4 days or 5 days, usually in the short days presentation, a febrile patient underlying diagnosis will be infective episode. So now infection involving the respiratory tract as well as GI tract. But abdominal pain doesn't mean GI tract always because there is a kidney, there are some other organs also. But if patient have the diarrhea, loose motion, then we can think that patient GI tract also involved. Then should we ask other point or not in the checklist? This is the main area of discussion today. How to utilize the checklist? Should we check one by one? Do you have the genitourinary, that is a dysuria frequency? Do you have joint pain? Do you have myalgia, rash, wounds? One by one. What Dr. Javed you are thinking or any other colleague? Patient second question answering, I am having the cough, for example. with sputum or productive cough. Should we ask the lower other points one by one?
I think, depending upon time, I think 3 minutes would be difficult to ask everything.
Yes, yes. So depending upon time means really you will not have the 10-minute time only for talking, right? So this is the preparation time for the OSCE. You will not have time. And it may not be practical also to ask. Whenever patient having the symptom, usually patient is to say. But here occasionally you need to focus separate point occasionally that do you have this thing as a complication or as associated other symptom, but how to cover these, it is the consultation technique in the exam. Patient telling cough sputum and other, but I need to know about these also. So how to ask these? We are asking that, do you have any other problem again? Okay, Dr. Javed.
Yes.
This is the key. This is the communication key with us to know, do you have any other problem? So in the primary time, initial time, you almost cover each and everything. Okay. But again, I like to add you, a patient presented with the fever now, patient having nothing, but you are thinking patient might be a patient of dengue because dengue is endemic now. For example, patient telling that only doctor, I am having very fever, very high fever. Already you got the temperature before in this upper part points. In the upper page, we have shown that onset, progression, duration, record of temperature 103 or 104 degree, many other things, and including red flag, you could ask earlier better. But about the diagnostic point of view, from the list, system-based symptoms for the dengue diagnosis, what will be very important symptom? Specifically, we need to ask.
Fever, headache, and the other
Uh,
GI symptoms.
Yeah, all symptoms are important, but if I ask you very important, which is very common for the dengue, that should be asked.
Fever.
Fever already said to you, you are actually dealing a patient of fever. Initial impression, you are thinking it could be a dengue. For example, acute fever in endemic
Rash,
time, rash.
rash.
Okay, could be. But I am waiting for other word also. Who can tell? Dr. Hamada is here. HD.
Joint pain, sir.
Headache.
Joint pain, okay, can be any more important than joint pain for the dengue.
Headache.
Vomiting, nausea, vomiting.
Vomiting is a GI disease, doctor. Maybe gastroenteritis, food poisoning could be GI disease. But the dengue, why not myalgia, doctor? You can see the myalgia. What is another name of dengue fever? A traditional name, rather to say,
Bone
break
break fever.
bone fever. Is it bone fever? It is actually bone fracture, doctor.
No,
It
no,
it is
it's like
it is
that.
it's
Fever
not
is like
bone fracture. It is like fractured bone, but actually pain of the muscle. Okay? Body ache. Body ache is a milder term usually. Actually, the pain, severe myalgia is one characteristic feature of the dengue. But whatever you have said, this is also possible because this is a viral disease. Even patient develop jaundice uncommonly though. But joint pain, side by side, you are thinking a patient of dengue, but patient diagnosis could be chikungunya. So, what question very important here in favor of chikungunya?
A special type of rash in chikungunya.
Joint
What
pain.
a special rash, Dr.
Joint
Javed?
pain.
Okay, Dr. Iram, be connected. Dr. Javed, what a special rash can help you to say this is chikungunya?
Joint pain.
Dr.
No,
Javed cannot tell.
in the skin, I think there is, I think, big lesions, maybe
Yes,
pus.
yes, yes. Rash can happen in many viral disease. But whenever you are confronting a differential of the chikungunya for dengue, differentiating point will be the joint pain or joint swelling or the features of arthritis. Okay, Dr. Javed.
It will be in chikungunya will be joint swelling.
Yes, this is the mainly clinical distinguishing features of the chikungunya from dengue. pain and swelling means actually arthritis. And the chikungunya word meaning also, patient become handicapped like, cannot move at all for the severe joint pain. Understand, Dr. Javed?
Yes, thank you.
So whenever you come across in the OSCE session or even your clinical practice, keep in the mind that patient might have many other problem from there. For example, your dengue suspected or chikungunya suspected patient may have headache, may have vomiting, many other thing. But which symptom, additional symptom, system-based symptom will be differentiating symptom for the diagnosis? That should be asked. Understood, Dr. Javed?
Yes.
That is my message today. These checklists actually created for you to give you as information box. All informations no need to be asked. What we will ask, it depends upon our mind, what I am thinking about the patient. I think we can go down now. So all of the headlines we have to think in this technique. Now for the febrile patient again, the exposure history. Why exposure history is important for febrile patient? All the data given there. Okay, Dr. Javed, is the screen clearly visible, Dr. Javed?
Yes, it is visible.
Yeah, other colleague also, please, you can come into this discussion. That here are many points. You can add other points also, but these are the till now available maximum points we need to ask. Exposure. In our history sheet, in our basic history sheet, there is no point of exposure. Exposure usually may be a part of the social history, socio-economic history. You see diet, smoking, alcohol, lifestyle, travel, many other things. You can see there, just to compare in the right side box, the social history. From the social history, seek contact, travel and contact somewhere. So just one point we like to discuss from there. Our patient is febrile patient. For example, is an acute fever, whatever. So anyone can explain any point to correlate with the diagnosis from there, from this point, doctor? Any colleague about the exposure? Otherwise, Dr. Javed can try.
Just like a
Dr.
measles
Iram.
contact with measles,
Yes.
measles and chickenpox contact.
Okay. Cheek contact. So try with another point down. They have given some example
Private,
also, right?
private
Some private issue. Is it? If
HIV, HIV,
HIV,
sexual.
sexually transmitted disease. So it is written as in our checklist, if relevant. Why it is relevant? If relevant, it is up to you, because you started the talk to the patient, her personal life, exposure. The exposure is a point is coming now. If he has some travel history and you are thinking that patient presented with the genital secretions or others in the systemic inquiry, genitourinary problems are there in a young female, you may think that it could be sexually transmitted infection. So you need to ask about the sexual history. The technique will be that if you cannot reach to a point, a specific one, you have to ask almost each question. And this type of strategy not acquire the taken in the exam hall, because exam is very standard, simpler way. In the real life, we might be puzzled that patient, whatever you are asking, patient telling no doctor, no doctor, no doctor. In the meantime, you need to ask each and everything. But if you can focus up to there before exposure history, you are thinking that it may be sexually transmitted disease. And then if you ask that about with whom, there is some technique, asking the private issue. If you don't mind, I like to ask some private information. It is very important for the diagnosis and other. So with whom you are living, with your husband or other? Do you have any partner other than husband? Like that, by maintaining the privacy. It could be the relevant question as exposure there. Respiratory exposure, you see, exposure to the occupational exposure. Though usually occupational lung disease are commonly chronic disease, patient might have a low grade fever also. So it could be another point of the exposure also. Exposure, again, exposure to the mosquito bites, which is very important for the mosquito bite, doctor. Again, anyone, please quickly answer. Exposure to the mosquito bite. What disease, febrile disease we can think of? Quickly, please.
Dengue, malaria,
Yeah.
Congo.
Yes, dengue, malaria, again chikungunya also, is not it?
Yes, chikungunya also.
Yes,
Chikungunya
yes.
also the mosquito related. So you see, this is called the exposure history. Again, it is in your mind. And a febrile patient, I need to ask about the exposure issue. In the hospitalized patient, commonly, or even in the general practice also, by whenever we advise the injectable to take at home, common disease is enteric fever. Patient may not actually be agreed for the admission. So we take a mutual decision. Patient will take injectable by self, but with proper guidance, suggestions. So patient might have the IV cannula in the hand. Okay. In some urologic cases, patient would have catheter in situ, but patient is not admitted even in our general practice. Also, we are following the patient. Is not very rare. Dr. Javed, what do you think? Patient having the catheter and coming to the chamber for the follow up, is not it?
Yes, as bedridden patient or I mean some
Yes.
chronic disease.
Yes. So any febrile patient, catheter related UTI could happen also. So we have to focus there also. I think it's a very marvelous checklist given to you. According to your suspicion, you need to search for. Okay. Come down, please. Treatment history. Treatment history relevant for the diagnosis as well as for management also. For the diagnosis, how you can explain, doctor, treatment history for antibiotic history is important. For example, patient getting antibiotic or not, it can help in diagnosis. Who can explain? Anyone? You took the history of antibiotic. It can help in our diagnosis, acute patient management. How? Very simple. Patient having the viral illness, but we are thinking it is maybe bacterial disease. Whatever we give the antibiotic, patient will
Antibiotic
not
induce
recover, right?
colitis.
Yes. Viral disease, but antibiotic is not working. It is very, very true. Patient took antibiotic from the medicine shop. You are taking the history. It could be helpful also for the diagnosis. Moreover, antibiotic, patient is getting one. You are thinking enteric fever, for example, you have to change the antibiotic. So in the management part also, again, patient getting proper antibiotic, perfect antibiotic. We need to continue the same antibiotic in the proper dose. So the drug history in the treatment history, not only for the diagnosis, but also for management and other. That we discussed what Dr. Javed, uh, what I say, read out before for us. These all the informations not only for the diagnosis, for management also relevant. Each and every point, what we are discussing, each and every point for 6 or 7 points are there. That understanding we should develop in our mind. So I am just now rapidly going down. Past medical history, these are the points. Already, doctor, please, you can ask me each and everything, whatever you want to know. Otherwise, you can follow. Drug allergic history is there. Drug allergy, especially antibiotics. Again, antibiotic allergy. Because common drug which produces allergy is the antibiotic, which is number one, penicillin. So if I give any amoxicillin, ampicillin, or penicillin group antibiotic today, we must ask it. Whatever the for the febrile patient, definitely antibiotic allergy is important. Our patient may not be febrile, maybe asthma patient or other patient, but asking the drug allergy is mandatory. Now come to the social history. Already we discussed before in the exposure part, travel could be part of the exposure, including other social issues, personal life, smoking, alcohol, family members with fever. So a patient having the other family member with the fever, minimum we can say that what could be a possible etiologic clue, Dr. Hamadar. At the same time, all other members of family member, all other family members affected with the fever. What could be the etiology? If it is infective disease, more likely etiology.
Tuberculosis.
Sorry, doctor, we cannot hear you.
Sorry, tuberculosis.
Yes, if it's a chronic disease, could be tuberculosis, but acute fever 4 5 days. What we find commonly?
Viral infection in the throat.
Viral infection. Viral infection. Commonly flu, right? Influenza. So this is also important, that what about other family members? So it is called the family history. Family history, traditionally, we are thinking about the hereditary disease, any disease running in the family from before. This is one way. Another, family history indirectly for practical purpose, that again the contact or surrounding people's also suffering from the same illness or not. So this is that social history part in the fever patient. So I will tell you something very exceptional. Usually we don't ask. Otherwise, you are very habituated to ask about. Only this focusing. In general, very few things I will give you or tell you today, that you will be sometime astonished. Oh, this is very important. I hope you will agree with me also today. So now the patient concerns and others, this is not for the diagnosis. You know, the courtesy of the consultation, idea, concern, expectation, including the impact in the life for each and every symptom. So now going down, again, you see in the right side, all are given. We actually we were thinking how to make a data sheet in this way. So these are the data sheet. All are incorporated in this right side box. And this is very open for everyone. So from the examination, the history part up to this, more or less, of a febrile patient. Now, the less, the data collection is always bigger part. How many minutes we actually allocated there, Dr. Javed? Maybe 3 minutes, 30 seconds, is it?
Yes.
It is just an assumption. It is not very hard and fast. To ask this thing, 3 minutes, 30 seconds. And the initial introduction, greet and meet, 30 seconds. So we finished near about 4 minutes up to this. We discuss a lot, but your summary will be very less. Targeted question should be asked. Focus question should be asked. Okay. And then in the examination part, already we have shown you before the right side box, small size given. So immediate when we are asking or talking to the patient, we are observing the patient. Observation already started when we are talking. Okay, so this from the chart. All things are there. Again, reminding you, everything actually not needed to be checked. But we should keep in our mind what I need to examine, what I need to examine there. So patient looks ill, toxic, rash, pallor, jaundice. By just simple visual impression, you can identify. Hydration status for the fever. It could be a red flag if patient is dehydrated. Okay. So this thing, and the vital sign, including the oxygen saturation. Oxygen saturation, almost all vital signs should be checked. Minimum pulse and blood pressure. Pulse and blood pressure. Respiratory rate may not be measured and not needed to be if patient does not have any breathing problem. But pulse and blood pressure, by observing only visual observation, it is not identified. Okay, but patient complaining the fever, we need to measure the temperature in our chamber, in our real life. But in the exam hall, usual instruction given in the exam, temperature is so and so. You don't need, no need to measurement there, but it is important point. Similarly, oxygen saturation by the pulse oximeter. You can see in the right side orange box. Pulse oximetry also mentioned. According to your patient situation, even in the febrile patient also, patient is not very severe, toxic and other, no need to check the oxygen saturation. If patient have even the minimum respiratory distress, then oxygen saturation by the pulse oximeter is important. Okay. After this, come to the systemic examination. Again, it will be targeted. Which system? Already you understood from the symptom before, patient having the cough. This is the respiratory system. Patient doesn't have any specific symptom related feature, only having the myalgia, not a specific issue. It could be the viral disease. If patient complain the joint pain initially, then we will go to the musculoskeletal system, seeing the joints, pattern and others. So according to the target, our target, we are examining the system-wise examination. This is a part of the general examination for the febrile patient, lymph nodes, rashes, PTC. Already you talk about the rashes and others. Now have a general look to the patient overall, to the exposed part, then focus to the respiratory, cardiovascular, abdomen. These are the location of the febrile disease. Location of the febrile disease. In the cardiovascular, capillary refill, it is not only for the cardiovascular infective disease, rather is a part of the complication. If patient have developed acute circulatory failure, capillary refill. So you started the examination in the hand. You see in the first point in the hand. Whenever during talking, after measurement of the vital signs, you are thinking that patient might have acute circulatory failure. So whenever you touch the hand initially, definitely you will check capillary refill time from the very beginning, very beginning. And the abdominal tenderness and hepatomegaly there, according to the abdominal problem, you will examine. You don't need to examine each and everything. Any patient having the cough or upper respiratory symptom, so we have to see inside the mouth, tonsils and others. Any nasal discharge, you need to examine the nose. Any ear discharge, you need to examine the ears. So accordingly, you will do it. And the later part, dipstick test. Again, from the, it is called the POCT. POCT. So may I ask doctor, why dipstick is important for a febrile patient? What clue we can get by dipstick test according to the patient presented with the fever? Dr. Javed.
UTI.
UTI, yes, urinary problem.
Okay. Any other clue can we get by dipstick test? Patient is febrile, okay. You are telling only in the point of infective disease.
Pyelonephritis.
Pyelonephritis, how can you identify by the dipstick? You can say UTI by the, you can see
Yes,
the
sugar.
sugar,
Sugar.
yes. How sugar can give an idea that patient having the infective disease?
Is immunocompromised?
Sorry, doctor.
Is immunocompromised? If you may
Yes,
say.
sugar, if presence of sugar may indicate that patient is diabetic, may indicate, right? Urinary sugar is not a diagnostic marker, but impression could be there, diabetic. And then any other clue? If patient is diabetic, many days before, what other finding we can get by the dipstick test in the urine?
Albumin.
Albumin.
Proteinuria.
Yes, proteinuria. It can indicate the renal damage. Okay. Now next question. Again, your patient is febrile. You got sugar in the urine. What will be the next POCT? Though it is not mentioned here.
Random blood sugar.
Fasting blood sugar is. Fasting
Fasting.
or GGT.
Doctor, in the chamber, you don't know about your patient fasting
Random,
or whatever.
yes, random
You
blood
can say
sugar.
the random blood sugar by actually capillary blood glucose, not the random blood sugar. Try to change the word, please. When traditionally we are telling blood sugar and other random fasting, these are the venous blood. Okay. There is a little quantitative difference between the capillary blood glucose and the venous blood. So in the chamber, you cannot do the venous blood. You have to send to the laboratory. But in the chamber, by the capillary blood glucose, by the glucometer. So after the deep stick test, then you decide that I need to check capillary blood glucose. Right, Dr. Javed?
Yes.
This is the method or technique I am discussing. You need to choose your point from there. What you will examine clinically, what you will do as a point of care test. For the febrile patient, minimum deep stick urine test will be almost universally important. Though we don't do in our practice because it may not be cost effective and other. And where we are practicing, if there is a nearby laboratory, especially in the Middle East country, I know about that we are practicing as a general physicians in the polyclinic or somewhere, many doctors are working. You send the patient to the laboratory, they are giving the result within 1 hour, 1 or 2 hours. It is possible. But those who are solo practitioner, single practitioner, and your laboratory is far away, you can establish a personal laboratory or POCT arrangement. There, you can check dipstick test as well as capillary blood glucose also. But if patient febrile, sugar is not there, there is no other findings in the urine, maybe only features of the UTI leukocyte esterase are there, you may not check the blood sugar subsequently immediately there, but only dipstick urine is enough. Okay. Finally, come to the management overall febrile checklist. So it is a non-specific checklist for you. Your diagnosis you know about. It could be the viral fever. This is very common even in the exam also, OSCE exam. Maybe dengue or chikungunya or those who appear at the exam you know about. Or could be pneumonia, UTI. These are very GP related diagnosis. Anyone will be there in your diagnosis almost. Even those who attended our previous OSCE, the recall session, you know about it. Not beyond that. Rare disease as a febrile patient is not there. It could be rather a malaria we can add there. Malaria, travelers in the South Asian hilly tract visit. So ideally, your diagnosis, if it is non-specific, in general, suggestion is that you mention 3 disease in general as a differential diagnosis. 3 disease plus 2 serious illness as a red flag. Red flag. So sepsis could be red flag here. Okay. Even dengue could be red flag if dengue is severe dengue, for example. But again, don't think that you need to say 5 diseases. It is an assumption. Just understanding that I will think 3 differential diagnosis. But if your diagnosis obviously UTI, you don't need to say again 3 differential diagnoses because it is very clinically, confidently we can say it is a UTI. UTI. Even only one disease is enough to say. I am thinking this is enteric fever. Keeping in the mind enteric fever, we are giving the general management, then we will go for the investigations. Okay, so, but again, if it is non-specific diagnosis is less common in your OSCE, remember. You will reach a diagnosis. And so in the management part, I will show you the management a little later. Again, this slide, look at the right side box just to compare how to explain these and other. In the below, in the management, just diagnostic impression, you are explaining to the patient this thing. Now come to your action plan. After explaining the diagnosis, you need to do the investigation plan. In the exam, you need to say one by one. Report may be there, may not be there. So for febrile patient, almost many of the investigations are needed. But if your diagnosis is enteric fever, you may not advise chest x-ray. You may not advise dengue, NS1 or IgM. This is true. So again, this is again your checklist. This is an accumulation of information in your checklist. You will decide by yourself. Keeping in the mind, I am investigating the patient, keeping the mind these right side points. Okay. So, if I ask you again, just to cross check, for example, chest x-ray. Your diagnosis is dengue. Your diagnosis is dengue, probable diagnosis. And you are advising NS1 antigen or antibody, whatever the test. But you are thinking that I need to advise a chest x-ray. So can you tell me from these 8 points there, which point we are utilizing to check chest x-ray in a suspected dengue patient? Please. Anyone? Not Dr. Javed, other colleague I am waiting to hear.
Complication.
Which complication by chest x-ray?
Uh, Pleural effusion, yeah.
Very right, very right. Pleural effusion. So when I am suspecting pleural effusion, always all patient will not have pleural effusion. So all patient we don't need to do x-ray. But x-ray we are planning because I am suspecting patient might have pleural effusion. For which complaint, doctor? Or for which general or clinical examination finding we are advising chest x-ray?
Oxygen saturation and shortness of breath.
This is one thing. And in the
Degree
chest
of
examination, we are getting features of the dullness in
breaths.
the percussion. Bilateral dullness is there. Okay. So we are thinking patient might have pleural effusion in the dengue. For this reason, we are giving advice for the chest X-ray. This is the way. Whole the things not important. Okay. If indicated again, different organ or COVID test for the diagnostic purpose, you can advise as such. Suppose nowadays COVID is very minimum, almost no. So nowadays we are not advising COVID test, but dengue is still there in the South Asian countries. Chikungunya, they are enteric fever. Throughout the world, enteric fever is endemic. So blood culture commonly. Okay, if fever persists more than 7 days, we are thinking it is enteric fever. Vidal test, very poor man test, very less informative test, better to avoid. But somewhere in the poor setup where blood culture not there, other investigation not there, still as an Vidal test, cheaper and available, easily to be done test, we could utilize. You could utilize ultrasonogram of the abdomen. So again, in the dengue patient, if you think that patient having the tummy pain, upper quadrant pain, ultrasound may be relevant. For which purpose ultrasound may be relevant? Check from the 8 point. Please again. Our discussion today, I think, is very important, Doctor, technically. Those who
Yeah,
are not participating.
liver abscess and
Liver abscess is not common, Doctor, in the dengue. Rather, cholecystitis is common.
cholesterol, correct.
Cholecystitis is common. So to see the gallbladder, ultrasonogram of the abdomen with special attention to the upper abdomen or hepatobiliary system, we can mention, but not for each and every patient. Okay. So again, you see that actually whatever investigating for the diagnosis, for differential diagnosis, for complication, for consequences or comorbidity, other, same thing, same thing. If you can fit your thought process in the exam, it will be very easy to pass the exam. So after everything, your last, the management plan 1 minute you are telling about, you will do and you will give antipyretic, fluid, hydration. If the red flag is there, even needed, you will send the patient to the hospital. For example, refer emergency if hypotension, shortness of breath, chest pain, confusion, meningitis sign, persistent high fever. It means that at the end of 7 or 8 minutes, especially in the OSCE exam, you already able to get these points. Then your management plan will be the referral. Okay. Antibiotics only if bacterial suspicion. You can start antibiotic, then you can refer or you can send patient back home and come back. In the follow-up, in acute infective illness, commonly or acute febrile patient, better to be seen after 1 or 2 days. Or tell the patient to come to see you again. Finally, for passing the exam, extraordinary clues. You must give home care instructions, safety netting with the red flags, and when to return to you or go to the emergency department. I'm telling for the exam purpose doesn't mean that it is irrelevant in our real life. It is relevant for the real life also. This is the extraordinary marks and very good mark you will get. So don't forget this thing, home care instruction, safety netting information, and the reason to come back. And finally, closer. This is very prototype informations closer, check understanding, asks questions, thank the patient and wash the hand. And you will wash your hand also. And if patient you do something there, if needed, you can just make a cleaning and give the patient hands also to wash or other if needed. But it is not practically needed. Your hand should be washed. So these are the structure for the febrile patient and different headlines for you, and we tried the best for you to give a time slot especially designed for the OSCE purpose, 1 minute 2 minute like this. You may take here, for example, in the management part, in the finally the telling the management part, 1 minute 5 second 10 second, no problem. But our plan will be we have to finish within 1 minute this talk to the patient for each and every patient. So in this way, by our thought process, we design the time slot for you. Whenever you are appearing, whenever you are practicing rather with your friends and others, try to maintain this time structure. And we do it. We do it also in our practice session. So these are the things, doctor, for your febrile patient relevant checklist. Repeating the word again as a bottom line, all the points are not needed to what I say, explore in a febrile patient. But these are the whole content of a febrile patient, your checklist in your mind map, you will utilize according to your skill. Now, how to utilize it? Practice, practice, and practice. Without practice, you cannot utilize any checklist. So for all of you, doctor, especially those who are practicing with us, we are developing the checklist already. Those participants, we have provided 5 patients checklist in the last open session. Some of you attended. In coming session also, we will be providing more checklist, and we are preparing accordingly suitable for you also in your practice. So this is from my talk, doctor. If any question in your mind now, few seconds, we can stay here. Anyone, please open the mic regarding the today's discussion.
Yes, Dr. Usman,
Please.
thank you so much. It's a today is, I think, an excellent session. Just what I viewed that you have to give more time to history with data gathering, is 3
Yes.
minutes,
Oh, yeah. I
and management. Examination, I think, is less time, maybe 1
yes,
minute.
yes. Very good observation. I can give you explanation there. Already we discussed before in the examination skill, maybe one day. So please, other colleague will be with us. We have given the data gathering 3 minute 30 second. Usually history taking time will be more. In real life, it is also true. But how can you extend your time? There is a potential possibility. How? When you are talking, you could observe the patient. Is that it, Dr. Javed?
Yes.
I go down. When you are talking, you already started the observation there. Appearance, right? Cannula, hair changes, confusion. That means your examination already started. It is outside the 2 minute. 2 minute mean if you think that inspection, palpation, percussion, auscultation in the some part, here also needed 2 minute. And 2 minute is enough as a GP. Not to do each and every points. Again, it is called focus examination. Even in the palpation of the abdomen, okay, you may palpate each and everything. In the auscultation, very less. So you can skip the auscultation also of the abdomen because you are not thinking that I may get some finding in the abdomen as auscultation. In the chest examination, inspection, palpation, percussion, auscultation, you may skip some points there. Not all the 4 headlines could be explored there. But better within 2 minutes, if possible, to complete each and everything. For this reason, in the practice time, you need to develop your examination sign, targeted sign that I must see it. Nobody can make it actually for you. You have to make by yourself. So when you do examination allocated 2 minutes time, in the history time also you are talking, you are the observing your patient. So actually this is 2 minute plus time. Clear, Dr. Javed?
Yes.
Actually 2 minute plus time. It may be extended up to the 3 minute also from there. So in the other checklist also you will get this structured time slot. Again, it is modifiable. It is modifiable, not very fast and fast, but it is for the practice purpose we have shown here, doctor. Any other thing, Dr. Javed, other colleague, please to say?
Thank you, Dr.
Enough for the checklist today? Okay, doctor. So any other relevant question, doctor? I think we finished this now, prototype checklist for the fever, and no other thing also from my side, and the gratitude, thankful to all of you as you have participated. And finally, thank you very much, doctor. And this is our resource material you can avail from the YouTube link.